those 30% that have that pathological complete response do very, very well. But in contrast, the other 70% of patients have this residual disease, which means a pathologist can see tumor cells left over in that tumor bed after neoadjuvant chemotherapy. And even though those tumor cells are removed during the surgical resection, those patients do very poorly down the road. And unfortunately, in treatment, those patients really don't have therapeutic options. In particular, they have no targeted therapeutic options. We already know that their tumors were not completely responsive to chemotherapy, so using more chemotherapy down the road may or may not be effective. And so really we're just waiting for a recurrence in those patients. And so we have a real opportunity at that point in care to impact patient survival and the likelihood of recurrence. And so our goal was to use state-of-the-art molecular techniques to profile those residual tumor cells and see if we could find some clinically actionable alterations that are present in that residual disease of triple-negative breast cancer. So in about 10% of our evaluable triple-negative breast cancer patients in that residual disease, we found JAK2 amplifications, as you said. I think that that's very interesting. The finding that JAK2 amplifications were present in breast cancer has, to my knowledge, not been previously reported. Of course, we'll need to do confirmatory molecular analysis to, for instance, FISH or quantitative PCR to ensure what we're looking at is not an artifact, but we're quite sure that it's not. I think that the fact that interleukin-6, which is a cytokine known to activate that pathway, was higher in those patients is also a significant finding. It really confirms that that pathway might be active in those 10% of patients with residual disease with triple-negative breast cancer. And I think that the fact that we have right now JAK2 inhibitors currently navigating clinical trials and even approved for some inflammatory diseases really have the potential to impact a very easily definable niche of patients. And I think that the timing could be right to not only identify the biomarker, identify the drug, right? We've got it in clinical trials, and identify the patients and hit that in an adjuvant study. I think that I would be very encouraged to do that based on our data. That's not to say that it'll work, but we know that the JAK2 STAT3 pathway is involved in cancer stem cell-like behavior in breast cancer. And I think that the idea that these patients have residual disease after neoadjuvant chemotherapy and recur so soon afterwards is really consistent with this cancer stem cell claudin low therapeutically resistant type phenotype that we've observed in the laboratory.